Eh, let me start Renyanga and then where it's necessary, but then that's like it. It's like simule kaya gago meshalon. What have we been able to achieve that we would not have achieved without the state of emergency? Had we not had the state of emergency, we would have been forced to procure medicines locally. We would have been forced. We would not have the flexibility that we were able to have. Remember, when the president declares the state of emergency, the idea was for us to get the best bang out of the buck that we had. So it was very important for us to make sure we get the most out of it. Imagine getting a procurement locally at close to 250 million, which is what you have in the pocket, and not being able to go straight to the manufacturer to get that at about what, is that 30 million? So the same folks who sell these things to us here also buy from these manufacturers. So why should we restrict ourselves? Why should we limit ourselves and blow all that money when we can go to the manufacturers and get the same products at the fraction of that cost? So you see, when you grow out, now you spend 30 million to get the same amount you could have got here. You have change that you can now do to procure other lines of medicines, now procure reagents, procure other things also at a fraction of the cost. So that was the idea behind the state of emergency. And also, remember when it was declared, the president also said, should they be in need, right, that after or while we are going through the process that we need to tap into other areas to get funds, then we should be able to do so as a contingency, right? So we were very diligent, and we made sure that we get the most that we can from every tab. You said your other question was what data are we relying on to say we'll be okay by Christmas? Well, like I said, the state of emergency was for procurement. The bulk of the procurements has been done, and they have started coming in. So that is what is giving us confidence. But what we must not forget, and this must not go out of sight, is when we started, we were at a very, very low level. Right? So once they started coming in, we directed that everybody hit the equity facility. So they get consumed as they get in. Right? So we don't keep them, or the idea is not to keep them in facilities or at the central medical stores. Oh, look at that, we have 90% here. No, that is not the idea. CMS, they have to be in the shelves. They have to be prescribed and given out to people, right? And then you say it seems like CMS we were there when it started. Yes, we were there. And I've been there a couple of times too, wondering what so that how things are evolving at central medical stores. Like I shared, we did reflect on why is it that, for example, facilities would say central medical stores. And we realized so some of these things were the internal communications and lapses that we had. And once we figured that out, we're able to attend to it. So now no facility will tell you that central medical stores. So that's what we realized, right? And then there were issues of ordering, where folks were not putting in orders, where orders were coming in late, and we're addressing those as well, right? So those were some of the bottlenecks that we experienced. And in terms of when will we see things rolling and taking action against this and the other, well, you see, we want to do things properly, okay? Where we feel like there needs to be a proper investigation. No, we don't do that. We are a human rights government, but that doesn't mean you will get away with everything. Yeah. At the end of the day, it's a witch hunt, I was targeted. So we want to do things properly. Rest assured that there are processes that are ongoing that are seeking to address these issues. And indeed, We are transforming central medical stores. If you remember, Tautuna addressed the declaration. He said CMS had failed. And we're still saying that, right? Because it's not able to live up to the mandate. It needs to be restructured so that we don't find ourselves where we are. And that's a process that we're currently embarking on. Some of the issues involve some policy and legislative frameworks, and you'll see me championing this in Parliament, right? In the near future, this whole thing, it will be a thing of the past, believe me. And then, Jenny from Yarona, you asked if we've been having situations since August, and that things don't seem to have been improving. People have been losing life. Indeed, we may not have perhaps the figures that attribute that mortality directly to maybe a certain shortage of commodity or so on, but we do know. Because if there is anything you know about me, I go to facilities. I interact with the people, and I see their suffering, and I see that is what keeps me going. That is what energizes me. That is what makes me leave the office and go to both central medical stores and go to these facilities. People, what is the minister doing? Go to the facility. What is he doing? Go CMS. I am there because I am committed to this, because I see the suffering, and we want to resolve this, and I'm passionate about it. That is why we're doing it. So I may not have the direct correlations for you right now, but as to whether we are aware of the struggles our people are going through, and we're very much alive to it, and that's what's making us work very hard to make sure this thing never repeats itself again. You mentioned that DHMTs were reporting different stock levels about ARVs. You know, the issue of stock levels is quite interesting, and I picked it up too when I was going through the facilities. I'm a delivery man. Some facilities would hoard medicines and would have availabilities of about 79%, 80%. While the distal facilities, other clinics in the localities and so on, did not have those medicines. And then the question is, why are you hoarding? Is it that naturally you're just thinking, hey, let's hold on to what we have? But that's not our policy. At the clinics, the health posts, from the distribution centers and from the hospitals, no one is supposed to hoard. So to me, in that location, or 1,080%, I'm not impressed. That's not impressing me. Why are you holding on to those medicines? For what? People are suffering out there. Why don't dispatch? I've been talking to the legislators. I've been talking to the councillors. Talk to facilities about order. Let's find out who has what and how is the distribution. That maldistribution, we are looking into it, right? So that while other people are suffering distally. So that is the intervention that we've put in place. If you go to, I went to Kasane. You will not believe when I tell you, when I got to Kasane, they had so many medicines that they were even donating some to Zimbabwe. Sorry, loaning some to Zimbabwe. In Kasane, right? Yes. But folks will not tell you this. You need to go there and see for yourselves. And I invite even you, the journalists, right? Don't take somebody's word for it. Even my word for it, don't. You see? That's why I said, I invite you, go to central medical stores. When I was there last time, journalists were there. Go and see for yourself. Indeed, they are there. Instead of relying on, somebody on social media, a faceless figure, posting, oh my goodness, the gains, over the years have, dwindling, the UDC government, this and the other. There are no ARVs, there are no condoms. Hogwash. It's absolute nonsense, right? When you go to CMA, when you go to check, you find, no, but medicines are there. So you don't, right, in a situation early morning. And I don't appreciate it at all, because it's not grounded in fact. It's intended to cause anxiety. You want to stoke anxiety, and you get people fearful. You can't have people living like that. That's why I post these things out. After I post, You come for me, that's okay, but you're not going to abone. Despite what somebody from the opposition will stand up and say in parliament, trying to grandstand, medicines are there, right? So I invite you, go to facilities. Ask them, dispatch is happening on the daily. Call and say, have you received anything? The minister is saying this. What are you short on? The issue of ARVs, the lady director from CMS did mention that we didn't have a shortage of ARVs for children. We had low levels for ARVs, and even at that, we rationed them to say, while delivery on a weekly basis, there is nothing. Now, a sensationalist stand up somewhere and says, oh my goodness, the ARVs, things are bad, this government is terrible, this and the other. No, that is not it, right? We're doing that because we didn't want an area where nothing is going out at all. Understanding that that is not the desirable situation, and we are working towards curing that. And I'm very glad that that is going to be behind us. And then in terms of figures and, you're worried about NCDs, whether we are not going to relapse since we have these issues in liver diabetes. I got to CMS. You see, sometimes the issue is not that the medication is not there that they want. Suppose that they want 500 milligrams of a certain medication. And then that 500 milligrams is what's not available. I'll give metformin as an example, right? Somebody wants 1,000 milligrams. Somebody wants 500 milligrams. And then if they don't have that, they don't seek to say, but what else can we do? Because the same drug is there, right? Do you make 2 500 milligrams? Do you used to be able to split it? It's 1,000 and you split it, you cut it, right? Those kind of things. So the reporting is that, there is no anti-diabetic, when in actual fact, you just don't have that one. We order. Rematsaba did mention that even when people prescribe, they prescribe that which is familiar to them. So we end up getting different lines for the same thing. And our way forward is, let's stick with generics. Generics work, generics are cheap, they're very effective. A lot of countries are using generics, so why not? Why should we pay more for a brand to do the same thing? So that's with relation to that. And then Tato from Yarona asked about the pool procurement strategies and when will we have a seamless supply. The pool procurement strategy we are working with in the region because, like Rematsaba said, we realized that people are not too keen, right, to when you make an order, a small order, from a small country in Botswana, 2.4 million arguably. And Ghana is not like all of us in Botswana, take medications on the daily. So the numbers are even less that you are ordering. But if we bring ourselves together, like I've been discussing with other ministers in the region, Namibia, South Africa, Zambia, and so forth, it is our belief that once we have a pool procurement, Lalia SADC, not just that, even manufacturing, because we have to start manufacturing for ourselves. West Africa is moving in this direction. East Africa, North Africa, is even more advanced. Morocco, Egypt, they're even further ahead. Little now we want the same thing. And for it to work, looking at numbers, imagine if Botswana was then making ARVs for the whole of SADC. And then South Africa was making other lines, Namibia other lines, we wouldn't run out. And we would be buying from one another. We wouldn't have this challenge. So we are championing this, and very soon we won't have this kind of situation happening. The injectable. I know other countries are trying out the injectable, but remember, little now we have to do our own due diligence with BOMRA. It's something we are following very keenly. From my understanding, this injectable, you take it twice in a year, right? Imagine that. When somebody is taking medicine now, perhaps on the daily, and now there's an injectable that you take twice a year. This will not only significantly reduce the cost to healthcare, but also improve dramatically the quality of life for the people who are this. And that is where we want to go. So There is a lot of excitement around it. A lot of countries are jumping on board. Little now we are doing our own due diligence so that we make sure what we give our people, is proper. And then, Khaone from Yarona, you were asking about the value of what was donated. I'm not sure, I'll ask the task force to comment on this. I'm not sure if we have a monetary value since it's a donation per se. They may know the amount that they used to procure it, but maybe we can give you a sense in tonnage, right? Whether it's 36 tons, it's 36 tons for the ARVs, isn't it? 86. 86, oh my goodness, yeah, 86. Okay, 36 was the first one from UAE, followed by the 91 tons. Now there's 86 tons that is coming, right? So that is what is also giving us comfort that we'll have these things behind us. And what are the stock numbers? You see, the stock numbers, I wasn't sure whether you mean at the facilities or at CMS. Yes, so at CMS, currently, because the facilities downstream are not stable, we don't keep medicines there. As medicines come in, they go out, right? They go out to the facilities. So we want to get to a point where the facilities are fully served and then more at CMS, right? So until the downstream facilities are satiated, CMS will continue to push them out, right? And then what are the orders that have been made? And I'm not sure if you're asking in terms of the exact medicines or whether ARVs directly or paracetamol thing, or is that your question?
For those that are bought.
So for those that are bought, we took a whole list from central medical stores, right? What we need, we are coming into malaria season, ARVs, pediatric medicines, and all that. All that CMS historically needed, right? We have made sure that we are good and not just in the short term, 2-3 months supply. You said push it, make it 6-9, where you can get a whole year supply so that we don't find ourselves in the same position over and over again. Okay, we want to resolve this, and we're confident with what we have done, with the procurements that we have made, and with what's coming, that we are going to arrest the situation.
And how much has been